I hope you can see my screen now. Assalamu alaikum, everyone. Welcome to today's presentation. My name is Rajiv Yusuf Ali. I am a current level 4, and I'll present a case on breast cancer. Our patient for today is MN. She's a 32-year-old female from Kiambu. She's married. She works as a saloonist. She's para 2 plus 0. She was admitted on 8th June 2022. Her presenting complaint was right breast swelling for the past 1 year, HPI. The patient was in fair general condition until about 1 year ago when she started noticing a right breast swelling that was of insidious onset, approximately measuring 2 centimeters. The mass was centrally located, was ball-shaped, moved when touched, initially soft, then became hard and tender at first, but then became tender as the swelling increased. The right breast pain had gradual onset, was sharp, radiated to the back, was associated with a generalized headache and itchiness around the breast, was relieved by warm water compressions, was exacerbated by cold weather, and it was more severe at night. She reports that the pain has affected her everyday activities. She denies any changes the right breast pain and swelling with the onset of her monthly period or with movement. As the swelling progressively increased, the skin around the right breast became darker, was ulcerated, associated with purulent discharge that was foul smelling. However, it was non-dimpling and not warmer than usual. There was no associated nipple discharge, nipple retraction, swelling in the axilla, or changes in the left breast. She reported to have had occasional night sweats, but no history of significant weight loss, bone pain, fever, cough, difficulty in breathing, chest pain, or changes in appetite. She also denies history of abdominal pain or changes in her bowel habits. Patient has a positive history of implant use for the past 1.5 years and oral contraceptive pills for the past 6 months. She reports to have had her menarche at 14 years of age, no history of malignancy or family history of breast disease, no history of prior breast disease, no history of exposure to radiation, trauma, or breast piercing, no history of excessive alcohol consumption or tobacco use. She reports that she normally eats a balanced diet and she does not prepare her food with too much fat. After several investigations were done, including a breast ultrasound, a complete blood count, a chest X-ray, and a biopsy, she was told that she had a breast tumor, although she couldn't specify which tumor she had. Of note, our patient was pregnant with her second child and reports that this was the reason her treatment was delayed. She delivered at 34 weeks through cesarean section with no maternal or neonatal complications. She came to KNH on the 8th of June for a routine follow-up clinic. At the clinic follow-up, when part of her right breast completely sloughed off and she bled profusely. She was then admitted to ICU immediately, and she can't recall how many days she lasted there. Several pints of blood were also transfused. She was taken to theater on the 30th of June 2022, where a simple mastectomy of the right breast was done. The intra-op findings were as follows: ulcerated right breast mass, and the breast was resected with pectoralis fascia. Hemostasis was achieved. Sampling of the enlarged right axillary lymph node was done. Subcutaneous tissue opposed with buried interrupted suture, subcuticular closure of skin, and the site was dressed. Post-mastectomy, day 1 to day 3, the patient complained of dizziness, no pain at the surgical site. Patient was in fair general condition, and there was no jaundice, cyanosis, clubbing, lymphadenopathy, edema, wasting, or dehydration. The surgical site was dressed, and the dressing was not soiled and drained 150 ml of fluid. Plan: patient shown how to empty and record the potovac, encouraged to ambulate, encouraged to do circumduction exercises, continue with antibiotics and analgesia as per the T-sheet. Day 4 to day 6, there were no new complaints. The patient was in fair general condition, no jaundice, cyanosis, clubbing, lymphadenopathy, edema, wasting, or dehydration. Surgical site was dressed, the dressing was not soiled and drained 40 ml of fluid. Plan: open wound and change dressing, home with drain in situ. Come after 2 weeks in the breast clinic. Past medical and surgical history: she has had multiple admissions for the same presenting complaints. History of previous surgery, which was for the CS for her second pregnancy. No additional chronic illnesses, no known food or drug allergies, no history of fractures, no prior blood transfusion. Obs gain history: she's para 2 plus 0, She has routinely come to the antenatal care clinic. She has had 2 prior deliveries, one through SVD, and the second one, which is the most recent, through cesarean section with no maternal or neonatal complications. She usually has regular menses of 28 days, which last around 4 days, with occasional dysmenorrhea on the first 2 days. Family social history: both parents are alive and well. She has 9 siblings who are all alive and healthy. She's married and currently lives with her 2 kids and the husband, who are all healthy. She has active NHIF cover, no history of chronic illnesses in the family or history of sudden death. Systemic review: CVS, no shortness of breath, no palpitations, no limb swellings, GUT, no flank pains, no dysuria, no urgency, no frequency of urination, CIT, no dysphagia, no odinophagia, no heartburn, no abdominal pain, CNS, no headaches, no loss of consciousness, no visual disturbances, musculoskeletal, no myalgia, no arthralgia, no bone pain, cutaneous, no rash, bruises. Summary: I'm presenting a man, a 32-year-old female from Kiambu with 1 year history of right breast mass which ulcerated about 2 months ago and was admitted to ICU on the 8th of June following sloughing off of part of the right breast, leading to profuse bleeding and subsequent blood transfusion. She has a positive history of OCPs and implants. She has had chest CT and core biopsy done with inconclusive results. General examination: I found a young African lady who was in fair general condition. At the moment, she was lying supine, fully alert and oriented in place, person and time. There were no obvious signs of respiratory distress or wasting. Her vitals were as follows: her BP was 108 over 64, pulse rate was 88, temperature 36.5, rest rate was 16, SpO2 was 94% on room air. She was not jaundiced. There was no pallor, no cyanosis, no clubbing, no lymphadenopathy, no dehydration or edema. Systemic examination: on breast examination, the right breast was dressed, not soiled on exposure. There is a diagonal surgical incision across the breast with surgical sutures in place. Chest examination: on inspection, the chest was symmetrical and moving with the respiration. There were no surgical scars or deformities. On palpation, the trachea was centrally placed, and there was normal vocal perimeters. On percussion, it was resonant bilaterally. On auscultation, good bilateral air entry, and no more vesicular breath sounds. On CVS examination, inspection, symmetrical chest moving with respiration, normal active precordium, no scars, no devices in situ, and normal JVP. Palpation, the apex beat was palpable in the 5th intercostal space. Mid-clavicular line, no heaves, no thrills palpable. Auscultation, S1 is too hard, and there were no murmurs. Examination of the abdomen. In inspection, there was normal contour, movement with respiration, no scars, and no superficial dilated veins or masses. Palpation, there was no tenderness, no obvious organomegaly. On percussion, it was tympanic across all the quadrants without any shifting dullness or fluid thrill. Auscultation, there was normal bowel sounds. CNX examination, her GCS was 15 over 15. There were no focal deficits, and the sensory component of her CNS was intact. All cranial nerves were intact as well. Diagnosis was breast cancer. Thank you.
Dr. Jamal and Dr. Mohamed, the floor is yours. Dr. Jamal, are you in the meeting? Dr. Jamal or Dr. Mohamed Dahir, is anyone
Yes.
in the house?
Yes, yes. I'm hearing you, but the voice was a bit disappearing. Are you getting me now?
Yes, we're able to hear you right now.
Oh, I was asking, was there any association of the mass with pain? I'm just not the only the presenter, but the members.
Initially, there was no
And
pain, but as the swelling progressed, it started to become tender.
yeah, yeah, exactly. So the main importance of that is usually pain is usually absent in usually malignancies and fibroadenoma, but present in some other forms of breast lesions, maybe an acute inflammatory mastitis or an abscess, or maybe even fibromatosis. It's a very good indicator to usually bring out. There's some few things I wanted to inquire from members. Was there any nipple retraction? We saw the examination, but I don't know. I don't know whether I was also seeing a patient. And we want to discuss the significance of having some of these few things. Why do you have to ask for the patient, and what are the significance? I think that is the reason why I'm asking is that we really need to know what is the significance of knowing a nipple retraction, and what usually causes that, what happens in skin changes, why do you have edema, why do you have the orange peel appearance in patients with CA breasts. And I think my colleague will also ask for a few things in the history. Why do you usually ask? And then later we can go to the triple assessment, and then investigations for the specific investigations and investigations for metastasis, and then management. And that will be the approach of discussion. I don't know whether Dr. Dahir has another view.
Assalamu alaikum, everyone. Thank you, Dr. Jamal. I had sorry missed the majority of the discussion. I've had a bit of a technical challenge, but I think the gentleman has done well in terms of the history taken for that level. In terms of patient presentation, I would say technically majority of patients really wouldn't present in that manner, requiring an urgent admission for a complication of a breast cancer. I maybe remember this lady from one of the wards, and I've had her story, and it's an accurate assessment of really what has happened, what our young brother has brought up. I don't know how the format is, because this is my first participation, but the majority of it, if you take a history for a patient with a suspected breast cancer, majority of patients will present with a lump. That's basically what majority of patients will present, but they can present with different other symptoms. You can get patients who sometimes will present with a suspicious nipple discharge. You can have some elements of nostalgia that might be there. So what is really important is that for patients, it's a good history and a physical examination. The approach that our colleague has taken was right in terms of you need to elucidate everything that the patient really says. If a patient tells you that they have noticed a breast lump, it's important that you go after that breast lump. And three things are basically important to be brought out. And this is the circumstances. How did you notice it is important? Of course, when did you notice it is important? How has it evolved is also important. And the relationship to menstrual cycle. These are the four major things that you need to bring out in these patients. The other thing, of course, you want to bring about is this an initial lump, okay? Or has she had lumps before that have disappeared? And this of course is very important that we need to bring out. Then the other things, of course, are associated symptoms for patients. Yeah. So is there an associated nipple discharge? Is there breast pain? And all those things are also important aspects to be brought about. In terms of a physical examination, really, what is important is a demonstration. But I would say a general physical examination, a focused breast examination, and an axillary examination. This at a minimum, this should be done. So for any patient with breast symptoms, the way to approach it is known as a triple assessment. It basically means that you do a good history, the way he's done it, a physical examination, okay, imaging, as well as now, if the imaging is suspicious, then a biopsy to establish a histologic diagnosis. So this is the approach for patients. Then if there's any questions on treatment, then I would be glad to chip in, but I don't know how the format is. So I will stop there before I speak a lot. Thank you.
Thank you very much, Dr. Dahir. And I think my contribution mainly is the history has been very good, and you said as a triple assessment, one of the things we shall consider is the history, and the second thing is imaging, and the third thing is the tissue diagnosis. And then I think our format of discussion will be, let us see what is very much relevant in the history and why they need to be asked for. Why are you asking this, and what are the significance? What would be the possible reason for this? And then secondly, we go to the imaging modalities. We compare a few imaging modalities. And then thirdly, we go for the histological, the tissue diagnosis part of it, and then specific management. I think the basic thing for this thing is that generally we need to discuss, that is the general approach, not only to breast cancer, but any breast lump. That is the criteria, the triple, the dexterity, the way you say, the triple assessment. That is the major. one of the things that I have seen most of the times to inquire in any patient who has a breast lump is there are key things that we usually ask them. But members need to understand exactly why are we asking some of these key things. For example, when I was asking about the issues of the pain, one of the things is that it gives you, is this a benign lesion? Usually malignancies or cancers or the benign fibroadenomas are painless. So what brings the patient to the hospital is the lump. There's no pain, nothing at all. So the worry of touching the lump is what brings the patient to the hospital. But in the event that there is pain, then your thinking changes to an acute inflammation of the breast, either mastitis, an abscess. So that is one of the things that usually comes out in our history. Also, one of the things that comes about in history is any family history, the way it was brought up was very clear because the association, you know very well risk factors for breast cancer. And you also need to know, is there history, is the patient, when you are collecting the patient, you need to bring out, is the issue of breast cancer, is it primary or is it a secondary issue? I think that has to be very clear. The menstrual history was very clear, as captured by our presenter. So there are some few things I will wish to ask members if they are familiar with. And from our examination, before we go to the triple assessment and the management. And patients with the breast lump, I've seen most of us, we usually ask if they have skin changes or a nipple retraction. Any patient who has a nipple retraction, one of the significance is that it points towards a malignancy, and it comes as a result of infiltration into lactiferous duct. And also, their skin changes can be tethering, fixicity, or nippling sensation, and that one is an infiltration into the corpus ligament. And we have edema also. And the other thing I've realized is that sometimes we look for, is the mass fixed, fixicity of the mass to the chest wall. So it's also a very important thing when we are either examining or taking a history. So they are, and the way Dr. has said, no, usually most of the time people forget to examine the axilla. I think it's a very important area when you are doing a breast lump. So examine the axilla, you examine for supraclavicular lymph nodes, very important things that usually examine in a patient who has a breast lump. So I think that is a brief thing I will comment about the history and examination on a patient who has a breast lump. And most of the times, by the way, have an open mind. When you get a patient with a breast lump, just collect the patient holistically, and then the flow of this, like the way our colleague has given, it was the history is so much good, pointing towards see a breast. The history should be driving towards a diagnosis. So I think in the next thing we can go is the triple assessment thing. I don't know if members are comfortable with the what triple assessment about the clinical exam, things we have said, imaging modalities, the ultrasound, the mammography, the MRI, and then the tissue diagnosis, fine needle aspiration, the core biopsies. And then we also talk about other tests like the receptor status, the genetic analysis, and what is the importance of doing those tests. I think that is the next thing we need to discuss. And for me, I love it to be interactive so that some members can tell us some of the imaging modalities that are done with the patient with the breast lump and how each is superior to the other one. When do we do ultrasound? When do we do a mammo? When do we do an MRI? In terms of imaging, and then in terms of tissue diagnosis, we'll also talk about is it an FNAC or a core biopsy or an excisional biopsy, whichever form of the modality. And then we'll talk about the receptor status. I think that is the floor is open for the members to tell us the imaging modalities that are known for a patient with the breast lump.
Dr. Jamal,
Yes.
we had some few slides that we made up for breast cancer. Should we present
Okay.
that one first?
It's okay. We can present and we discuss.
Okay.
No problem. It's okay.
Okay. Thank you. Rajiv, kindly, I want to share my screen. Thank you. Oh my good Lord. Is my screen visible?
Yeah, it's clear.
Okay, thank you. So these are some few slides that I prepared on breast cancer. Our objectives today will be, as usual, we're going to see the epidemiology and then review the breast anatomy. We do a bit of types of breast cancer. We check the etiology, we check the risk factors, we see the clinical presentations. How does a breast cancer present? We're going to check the investigations, the relevant investigations. We're going to check the treatment. What are the treatment modalities for breast cancer? And we're going to check for the prevention and screening. We're going to review the breast anatomy. As we know that the breast is a modified sweat gland that is located between the subcutaneous fat and the fascia of the pectoralis muscle and the serratus anterior. It consists of mainly fibrous tissue and glandular tissue and also a bit of fat. We know that there is an anatomical part called the retromammary space, and this is posterior to the breast and anterior to the pectoralis fascia. We have what you call the axillary tail or axillary tail of Spence, which is very, very important in the breast anatomy, as it pierces the deep fascia and enters the axilla. We know that the glandular tissue consists of 15 to 20 lobules, and this drains into the lactiferous ducts, which converges towards the nipple. We have the lobules that are separated by fibrous septa running from the subcutaneous tissue. Some few minutes ago, he mentioned something to do with suspensory ligament of Cooper, which is very important in breast cancer. We have now, when we talk about the dimpling of the skin, later on in my slides, I'm going to discuss that. It has relevance to breast cancer. And if we talk about the arterial supply or the vasculature of the breast, it's mainly supplied by internal thoracic artery via the perforating branches. We have the axillary artery, which is the second division of the axillary artery. We have long thoracic, thoracoacromial branches. We have subscapular. All these are supplying. The venous drainage, it's mainly through the internal thoracic. We have the axillary vein, the lateral thoracic, and the intercostal veins. The lymphatic drainage, I'm going to talk about two main lymph nodes, the axillary lymph nodes, which they take the largest share, 75%. They drain 75% of the ipsilateral breast. And they're normally in 5 groups. We have the anterior group, we have the posterior group, we have the medial, we have the lateral, the apical. And once they have taken the lymph, they drain into the supraclavicular and the jugular nodes, and the other share, roughly 20%, is done by the internal mammary nodes. So they drain from the ipsilateral breast, and they account for about the upper and the lower inner quadrant. Breast cancer is the most commonly diagnosed cancer in Kenya, with an annual incidence of 6,000 new cases and 2,500 cancer-related deaths. Black women with breast cancer are more likely to be diagnosed at a later stage, and they have poor survival rates compared to white women. The thing is that the majority of breast cancer usually the largest share is taken by the white women, but when it comes to mortality, it's mainly the Black women that have poor mortality. So when does breast cancer peak? It's mainly postmenopausal, and its age-specific incidence increases with age, and starting from the 30 years of age and peaks at 60 to 69, and then it gradually declines in the 70 and above age group. Mortality is breast cancer is the second leading cause of cancer death in women in Kenya after cervical cancer. So how do you define breast carcinoma? This is a heterogeneous group of disease with distinct histological appearances that are based on immunohistochemistry and histological testing. Because of mammography and these imaging modalities, there's an increased detection of breast cancer, and especially mammography. It has helped to detect early disease, including ductal carcinoma in situ. These are some of the gross pictures of breast carcinoma that I was able to get from Google. As you can see, we have ulceration, we have enlarged breasts, and these are some of breast cancers that have been incised. What are the risk factors? The risk factors, we can divide them into modifiable and non-modifiable. For the non-modifiable ones, it include age. So as I mentioned, breast carcinoma, it mainly affects female, but let's also not forget the male population. It's roughly 1%. So it steadily increases with age as you advance. We have geography. Mainly the place where you come from, and then we have race and ethnicity. As I mentioned, the American, the Black women and the white women. We have diet, people who take a lot of fat diet. We have reproductive pattern. We have breastfeeding, which is women who breastfeed up to 2 years. They have a protectiveness of women who don't breastfeed. We have endogenous exposure of hormones, such as early menarche, women who get their periods, monthly periods at an early age. They have estrogen exposure. We have late menopause. We have late age as a first pregnancy. We have nulliparity. We have obesity. All these are because of prolonged exposure to estrogen. And we have exogenous, like hormonal replacement therapy. Family history. First degree relatives with breast cancer. If your family, your first degree relatives have there is a history of breast cancer in your family, there is a high chance that you might get the disease. We have environmental factors, exposure to radiations, toxins, cigarette smoking. We have benign breast disease. If you had a history of benign breast disease, there is a high chance that you might get a breast carcinoma. We have others. We have miscellaneous, such as a high-fat diet. We have alcohol consumption, and we also have oral contraceptives. All these are the risk factors that can expose one to getting breast carcinoma. I should not forget genetics. We have BRCA1 and BRCA2 mutation genes that are also involved with breast carcinoma. So we can talk about breast tumors, but for me, for these slides, I focused mainly on breast malignant, which is breast carcinoma. But generally, if you are supposed to classify breast tumors, we can divide them into primary and secondary. Primary, that it's the cancer solely arises from the breast, and we have secondary, which is mainly metastatic cancers. And then we can divide them, after that, we can divide them into benign and malignant. Malignant, it's cancerous; benign, it's non-cancerous. So if we focus on malignant, we have invasive and non-invasive. So invasive, it's cancerous, it's malignant, and it spreads to other organs. When we talk of non-invasive, it's mainly limited to the basement membrane, does not invade it. So it's precancerous, it's still its original position, and it eventually develops into invasive breast cancer with time. So the main ones, the main ones that I'll be discussing today will be ductal carcinoma, inflammatory breast cancer, and lobular carcinoma. So ductal carcinoma, we will have ductal carcinoma in situ, we will have invasive ductal carcinoma. Lobular carcinoma is the same, we will have lobular carcinoma in situ, and we will have invasive lobular carcinoma. And then the other one is the inflammatory breast carcinoma. So let's start with the ductal carcinoma in situ. These are malignant cells that are arising from the terminal duct, that is the lobular unit, and it's confined to the basement membrane because it has not yet invaded the underlying structure. So it's mainly limited to the basement membrane. And if you check under the microscope, you will see that there is distortion of the lobular architecture. So how does it present? It's if you do an imaging modality such as a mammography, you'll find that there's an abnormal mammogram. So there'll be clustered pleomorphic calcifications. Otherwise, the physical exam is usually normal. It has excellent prognosis if treated. So some of the treatment modalities include surgical excision. You can have a partial mastectomy, or you can even have total mastectomy, depending on the number of the lesions, the number of lumps that you have. You can also add an adjuvant radiation, such as tamoxifen, and even aromatase inhibitors. The good thing is that with ductal carcinoma in situ, it has a low recurrence rate. The lobular carcinoma in situ. So I'm discussing the non-invasive, okay? So we are still in the non-invasive, the ductal carcinoma in situ and the lobular carcinoma in situ. So for the lobular carcinoma in situ, it's just a little bit different from ductal carcinoma in situ. The malignant cells arising from the terminal duct, the lobular unit, and it's confined to the basement membrane, and there's no distortion of the lobular architecture. So how does it mainly present? It's normally an incidental finding. Okay, it's an incidental finding. If you check about the treatment modalities, you can have bilateral total mastectomies, and you can even have prophylaxis with tamoxifen. Okay, so how is the progression to cancer? It has a high progression to cancer. So it can develop into to invasive ductal carcinoma or invasive lobular carcinoma. So the invasive ductal carcinoma, it's the most common invasive breast cancer. It's the proportion is 70 to 80%. It's uncontrolled growth of cancerous cells originating from the ducts of the breast tissue. It has a decreased chances of recurrence. So how do we treat it? Surgery, radiation, systemic treatment options such as hormonal, targeted therapy, and all those. For the invasive lobular carcinoma, is the second most common histological subtype of breast cancer after invasive ductal carcinoma. and it accounts for less than 15% of all breast cancers. So this one is diagnosed at an older age. It has a more late recurrence than invasive ductal carcinoma. It might present with multifocal or bilateral lesions. It has an excellent prognosis, and it's generally very similar to invasive ductal carcinoma. We have other histological subtypes such as medullary carcinoma, mucinous, tubular, and they all have better prognosis than invasive ductal carcinoma. So for the inflammatory breast carcinoma, which is another subtype, it is an aggressive cancer. So how does it typically present? With a rapid swelling with or without changes in the skin. You remember Dr. Jamal talked about the yellow, the pure, the orange, okay? And there's also nipple retraction. It can be erythematous, swollen breast with or without palpable masses. So the underlying cancer is poorly differentiated and diffusely invades the breast parenchyma. It often resembles mastitis because of there's the erythematous swelling, there's pain and all this. So it normally imitates mastitis, okay? So how do you diagnose it? Its only reliable method is biopsy. And how do you treat it? Multimodal therapy. I'm going to talk about this later in the coming slides. So how does breast cancer normally present? So it can be asymptomatic or it can be symptomatic. So asymptomatic, it's mainly detected on mammographic screening because there's no symptoms that this patient is presenting with. Symptomatic, it differs from one patient to another. Because like one patient can present with these symptoms, with some of these symptoms, patient might present with another symptom. So you have to clock the patient thoroughly so that you can detect these symptoms from the patient. So you can have self-detected painless lump in the breast in more than a third of the patients. So mainly they present with painless lump in the breast. They can have self-detected painless lumps in the axilla. They can have nipple changes and overlying skin changes. We can have nipple discharge. You can have constitutional symptoms of cancer, loss of weight, loss of appetite, all this. If it is metastatic, they'll present with bone pain. They will present with fractures. They might even present with shortness of breath or jaundice because it has metastasized to other sites. So what are features suggestive of breast cancer? As you're doing a clinical examination on this patient, as you're doing a breast examination, what are the things that you have to bring it out to say that this is, I'm dealing with a breast cancer? So you check for the surface. Is it regular? Is it nodular? So you check for the surface. Check for the age. Is it poorly defined? Or does it look, are there areas that are resembling more of a normal breast tissue? Check for the consistency. Is it firm? Is it hard? Is it rubbery? If there is, check for tenderness. Is there any pain? Check for fluctuance. Check for the, is this lump tethered to the overlying skin or is it fixed to the underlying muscle with or without nipple involvement or discharge? Check for lymphadenopathy as well. So if this cancer, if this breast cancer has spread or it has metastasized, it normally metastasis locally, lymphatics or hematogenous. So for the local invasion, it can invade the skin and the subcutaneous tissue, and then it can invade the underlying ribs and muscles. The lymphatics, mainly through the axillary, the internal mammary. You can also have others such as the supraclavicular lymph nodes. Hematogenous, through blood, it goes to the lungs, it goes to the liver, it goes to the brain, it goes to the bone, adrenals, and even the ovaries. So now that I've taken you through the breast anatomy, I've taken you through the introduction to breast cancer, the risk factors, the clinical presentations. Now we are at the investigation. So how do you investigate a breast cancer? So the evaluation of breast lump is by the triple assessment. And I hope you guys have heard it very well that Dr. Jamal and Dr. Mohamed Dahir, they have told us prior, some few minutes ago, that there's something called triple assessment. So what is this triple assessment? So it's mainly clinical examination, a thorough clinical examination. And then you do a radiological assessment, either a mammogram or an ultrasound. And then you do a histopathological assessment. That is either a cytology or a biopsy. So all these three must be concordant for benign to have more than 99% specificity. You have to rule out malignancy. So what are some of the breast imaging modalities that we have? We have a mammogram, we have an ultrasound, we have an MRI. I could not put it within today's scope. I wanted you guys to know how does a breast cancer, how can you detect a breast cancer on a mammogram? What are the features? What are the features on the ultrasound? What are the features on the MRI? But because I did not want the slides to be too many, maybe one of the doctors might tell us a bit on what we can expect on in any of these breast imaging modalities. The breast biopsy, as I mentioned, we have cytology or histology. What are the two main breast biopsy techniques we have? We have fine needle aspiration and we have a co-biopsy, okay? So, and we also have incisional or excisional biopsy. So most people prefer fine needle compared to co-biopsy. As you can see, some of the advantages I've listed there, because fine needle aspiration is less invasive, it's less painful, it will give you a smaller wound, you see, does not even require any local anesthetics. Compared to co-biopsy, it's more invasive, it requires a large, it requires local anesthetics, it will result in a larger wound, it's more painful, there's the risk of complications higher, but it has a better diagnostic value. That's the advantage of a co-biopsy. So what are the investigations for distant metastasis? You can have a chest X-ray or a CT of the thorax. You want to check for lung metastasis, look for isolated hyperdensities. If you want to check for metastasis to the liver, do a proper liver function test. You'll see there's a raised ALP. You do an ultrasound of the hepatobiliary system. You can do a CT abdomen for the liver, or to check for the liver, check for the adrenals, or even the ovarian metastasis. You can do a bone scan, okay? You want to rule out if there's any bone metastasis. You want to do a PET scan. You want to do a CT or an MRI of the brain. So we're going to the staging of breast cancer. So we normally use the T and M. T for the tumor, N for the lymph nodes, and M for the metastasis. So we say it is T1 if the tumor size is less than 2 centimeter. If it is T2, the tumor size is roughly between 2 to 5 centimeter. If the tumor size is more than 5 centimeter, it's T3. And if it has extended to the skin or the chest wall, it's T4. Let's come to the lymph node. If there is no lymph node metastasis, we say it's N0. If it is metastasized to the ipsilateral and it's movable and it's within the axillary lymph nodes, we give it N1. If it has metastasized to the ipsilateral and it's fixed and it's axillary, okay, we give it N2. And if it has metastasized to the infraclavicular or supraclavicular lymph nodes, or to the axillary lymph nodes, or internal, or the internal mammary lymph nodes, we give it N3. Metastasis, if there's no distant metastasis at all, we give it M0. If there's distant metastasis, we give it M1. So that's how we stage the breast cancer. I hope this TNM staging is very clear to you guys. So this is basically it's in picture form: stage 1, stage 2, stage 3, stage 4. So how do we the prognostic? How do we give, or how do we know the prognosis of breast cancer? We normally use what we call the Nottingham Prognostic Index. So it's like an index. It's like you're calculating something. So you take a number which is 0.2. You multiply with the size of the tumor. Then you add to the node. You add the lymph node staging, the one that I showed you, and then you add to the grading of the tumor. So what are some of the prognostic factors of breast cancer? The size of the tumor will give you the prognosis of the breast cancer. Number of the lymph nodes involved, the grade of the tumor. You check for the hormone receptor. If it is tumor responsive to tamoxifen, or it is an intense estrogen receptor and progesterone receptor staining, which is a good prognostic factor, by the way. You check for the HER2 or the NEW2 expression. If of expression of HER2, NEW2 is a poor prognostic factor, which is, you have to know that one. You check if this patient has been ever treated with trastuzumab, Herceptin, or lapatinib. You have to check for that one. Triple negative breast cancer, that's a poor prognosis. You check for presence of lymphovascular invasion, which is also another poor prognosis. So this is the Nottingham Prognostic Index, the NPI. As I mentioned, it's 0.2 times the size of the of the tumor plus the nodes involved plus the grading of the tumor. So once you have calculated, now you come to this box. We check if your value, the value that you've gotten, if it is less than or equal to 2.4, that's an excellent prognosis. If it is less than or equal to 3.4, that is good prognosis. If it is less than or equal to 4.4, it's moderate 1. And if it is less than or equal to 5.4, it's moderate 2. And if your value that you've calculated, the index is more than 5.4, this is poor prognosis. So this one will guide you on the treatment, on the outcome and everything of the patient you are dealing with. So what are the 5-year breast cancer survival rates? If it is stage 0, yani if this patient has been diagnosed with breast cancer at stage 0, they have a high chance of surviving, the 5-year survival rate, close to 100%. If it is stage 1, close to 98%. If it is stage 2, close to 93, stage 3, 72, stage 4, 22. So it's declining as the stage increases. So how do you control? How do you manage breast cancer? So we can have local regional control and we have systemic treatment. So the local control is mainly surgery or radiotherapy. The systemic treatment is mainly chemotherapy, hormonal therapy, and targeted therapy. Okay, so let's talk about a bit of surgery. I know these slides are a bit intensive, but I did not know what to leave and what to include because everything looked important to me. So I'm sorry for boring you with a bit of this. I'm almost winding up. So we have surgery. For the surgery, we normally have, you can excise, or you can do surgery to the primary tumor, or you can do surgery for the axilla. So for management of the primary tumor, we normally have complete local excision and we have mastectomy. So this complete local excision, we call it the SLE. It's mainly done with breast conserving surgery. So the aim of this is to maximize the disease control, and you want to decrease the impact of the breast cancer on the quality of life. So if you hear of complete local excision, also called breast conserving surgery, it normally includes lumpectomy and quadrantectomy. Okay, you're just excising the lump, or you're excising that quadrant that is involved with that cancer. Okay, so quadrantectomy or lumpectomy. Mastectomy, you can have total or simple mastectomy. You can have modified radical mastectomy. You can have radical mastectomy. You can have extended radical mastectomy. So the only difference is that yani to the point you're excising the cancer from, yani up to the point you're excising the cancer from. That's what differentiates these kind of names. So if it is simple mastectomy, total or simple mastectomy, you're doing breast, and you're removing the breast tissue without nodal dissection. If you're doing modified radical mastectomy, you're doing breast, and you're removing the breast tissue with axillary lymph node dissection. If you're doing a radical mastectomy, you're doing breast, you're removing the breast tissue plus pectoralis major plus axillary lymph node dissection. If you're doing an extended radical mastectomy, you're removing the breast parenchyma skin sparing mastectomy, total or modified radical mastectomy with preservation of the significant components of the native skin of the breast to optimize the aesthetic result of an immediate reconstruction. So in short, you are trying as much as you can to spare the skin so that this person will not be disfigured that much. So how do you manage the axilla? You want to assess for the nodal status, you want to evaluate the prognosis, you want to determine adjuvant therapy. All this will come handy, so you can have your own time to go through this one. So you can another local management is radiotherapy, and it's normally done after breast conserving surgery or after mastectomy. Adjuvant systemic therapy, we have chemo, we have hormonal therapy, we have targeted therapy. So what are some of the chemotherapies? We have adriamycin and taxotere, which is a combination. So you can have that one. You can use that one on your patient, or you can use adriamycin and cytoxan with or without Taxol. You can have cytoxan, methotrexate, and fluorouracil. You can have cytoxan, Elens, and fluorouracil. So all these are types of chemotherapy that you can use on your patient. Then we have hormonal therapy. We normally have three. We have three main hormonal therapies. We have the selective estrogen receptor modulator. The some main ones we use is tamoxifen and tamoxifen or raloxifene. We have aromatase inhibitors, which have different generations. We have first generation aminoglutamide. We have second generation formestin. We have the pure estrogen receptor antagonists, such as the fulvestrant. Okay. We can also have ovarian suppression, gonadotropin releasing hormone analogs such as leuprolide or goserelin. All these are hormonal therapies that we can use. What are some of the targeted therapies? We can use HER2, anti-HER2 therapy, such as trastuzumab, pertuzumab. All these can be used as a targeted therapy. We have the CDK inhibitors, such as palbociclib, ribociclib. All these can be used. Okay. And then you can combine either the anti-HER2 or the CDK inhibitors if you want. So how do you prevent breast cancer? We can have primary prevention, secondary prevention, or tertiary prevention. So what are some of the primary preventions? So you have to eliminate the risk factors. And these are mainly the modifiable risk factors. If the patient is obese, he or she could keep she could keep a healthy lifestyle, so physical activeness. If the patient is on endogenous, exogenous hormonal therapy, they should stop and those kinds. So you just modify the risk factors that you can. Then cancer awareness, identifying the warning signs of breast cancer. Mainly through social media, there's a lot of awareness on breast cancer. So that is another way you can prevent at the primary level. Secondary levels, early detection. We can have self-breast examination. And I think Dr. Jamal or Dr. Mohamed Dahir can take us another day. I don't think time will allow us today. Another time on what how do we do a proper clinical breast examination. So teaching the patient on how to do a self-breast examination or doing a clinical breast examination or even imaging modalities such as mammography will be used as an early detection. Treatment, now that you have identified that the patient has cancer, breast cancer, you do a treatment. So you do, depending on the treatment modalities you will choose for the patient, surgery, radiotherapy, or chemotherapy. You can also have breast conservative surgery, which is effective and preferred for early stage. What are the tertiary prevention? So this patient already has an advanced breast cancer. What can you do for them? For palliative care, you can do breast prosthesis for aesthetic looks and everything. And then of course psychological support. Being diagnosed with any cancer, not just breast cancer, but any cancer comes with a lot of trauma and PTSD. So you can support your patient through psychologically as well. I believe I'm done with my slides. Thank you so much. And Dr. Jamal, Dr. Mohamed Dahir, you can pick up from there. Thank you.
Thank you. Thank you, Najm. Is Jamal here? Is Jamal still with us?
Let me check.
Can see him.
Let me check. Yes, he's here. Dr. Jamal is here.
Okay, great. I think we've lost some of our audience, like 15 of us, which is okay. You've done justice to the topic, I believe, wide topic. It's inherently also a very heterogeneous disease that presents essentially in varied ways. In terms of the way you've brought it, I think I really liked it. But the most important thing to remember really is that patients will either present with early disease, local advanced disease, or they will come with advanced disease, including metastatic disease. This is essentially how to remember breast cancer. Majority of it, what happens is that the biology of breast cancer really says a lot about it. Yeah, so that we can have patients really who will present maybe at a locally advanced disease that will do better than patient who has an early disease, but a very poor pathology, okay, biology, such as maybe a patient who has a HER2 positive disease, as she had put it, as opposed to a patient who has a triple negative disease. So the literature on breast cancer is really varied, okay? At your level, what is important is what I want to discuss. One, what is important is to understand how a patient with breast cancer presents. And our colleague who has done history has done a good job at it. Number two is, can we do a good history for these patients and do a good physical examination? Okay. Two, can we now investigate for the suspicious symptom that the patient present with it? With this is also important. Three, can we establish a diagnosis, then offer patient treatment? Okay. In terms of history and physical examination, very well. If you find me in Kenyatta, I can maybe take an opportunity to go through a physical examination of patient with breast cancer. So history, physical examination. The other thing is, if a patient has a suspicious lesion, what do we do in terms of imaging? And I think she's discussed that well. Majorly, we do an ultrasound or a mammogram for patients, and maybe in certain patients who have high-risk patients and in whom either an ultrasound or mammogram is equivocal, then sometimes you might use a breast MRI as an adjunct. But majority of the patients, if they're less than 40 years of age, we usually prefer ultrasound. They're more than 40 years of age, most patients will have mammography. And the two imaging modalities can actually be used as an adjunct with each other. Okay. One small thing that I wanted to correct about the presentation was that an FNA is superior to co-biopsy. Invariably, all patients with breast masses that are detectable, okay, whether clinically or via imaging, should be offered co-needle biopsy. This is a principle that you must remember, because a fine needle aspirate can give you cells. It cannot differentiate between a malignant disease and a benign disease. So where a core-needle biopsy may be done is maybe where there are breast cysts, but majority of fine needle aspiration, majority of the patients, we will advise that they have a core-needle biopsy. It gives you good tissue architecture, and you can really, for majority of patients, get a firm diagnosis. So remember that. FNA, minimal role. Most patients, we get a core needle biopsy. Remember this. I don't want to go into the nitty-gritty of the different breast cancers. I think maybe I will send a document so that you guys can have a look at it at your own time. Last but not the least, I want to say a word or two about treatment. I don't want to go into major things, but remember, treatment is either local regional or systemic. This is how I look at it. And this is at your level, I think, how you should look at it. We say treatment is either local regional or systemic. Local regional, two major modalities: surgery and radiation therapy. Okay? Local control. Okay? Then certain things that will be used to retard the systemic spread. And this is either three major things: endocrine therapy, chemotherapy, or targeted therapy. Okay? Endocrine therapy, basically patients who have an ER, which is estrogen receptor positive disease. Okay? Chemotherapy, patients who have certain pathology, or such as a triple negative, or HER2 positive, or in patients who have certain features on the post-op specimen, in whom we will give an additional chemotherapy. And chemotherapy, as you know, can be given before surgery, which is known as neoadjuvant chemotherapy, or after surgery, which is known as an adjuvant chemotherapy. Then we have certain targeted therapies that we can give patients. And this, of course, is things like a HER2 receptor antagonist, whether we do a single blockade or a double blockade, or other modalities that we are going to maybe discuss in another forum, things like PD-L1 inhibitors and all those things. So the treatment we offer patient is two things. Is it curative or is it palliative? Okay. If there's palliative, if these patients present with advanced, let's say, metastatic disease, most patients are given metastatic treatment. okay, and patients who present with early or local advanced disease that is amenable to surgery, of course, are taken through that pathway. I think that's all I'm going to say. I really love the presentations, and maybe we can have another forum on other things such as breast screening, what it means, because I feel like it's such a big topic in which we can't really discuss breast cancer in a single forum. Maybe one day Jamal, myself, or any of our colleagues will take you through maybe a treatment of breast cancer and what we think it is, and maybe other modalities of dealing with breast cancer. Thank you very much. Maybe my colleague can say a word or two, and then that is it for me. Thank you.
Dr. Jamal, are you in the house? I think he had some technical issues. I don't know.
I think maybe that is, maybe can take a question or two if there's any.
Okay, let me check in the chat box if there's any question. No, there isn't any question in the chat box.
Okay, there being no any other contributions, I don't know, Najma can lead us, and then we can don't know how, because this is my first time I'm here, so I don't really know how things are done, but
Yeah.
That is it for me. Thank you.
Yeah, we can. I think. Thank you so much for to both of you for giving justice to the discussion, because breast cancer, as you mentioned, it's very wide, and we cannot discuss it in one sitting. So maybe if we get another time, we can discuss more on it. Thank you so much to both of you, and yeah, we can stop here for tonight.
Assalamu alaikum. Bye.
Wa alaikum salam.